Hello, everyone. Good evening. Welcome once again. This is the Lung Cancer Connect event, and this is an event organized by Pfizer, and it has the objective of discussing a little bit on the treatment of the non-small cancer and SCLC. We all know that. Well, I am a physician at Rio de Janeiro, and then we have the privilege of having the presence of Dr. Todd Bauer, a international reference in the treatment of lung cancer. And then he will give us an overview of the disease and discussing in depth the data, mainly of lorlatinib for the treatment, which was one of the approvals. That was the most recent one that we have in our national scenario of lung cancer. As you know, Dr. Todd Bauer is an oncologist. He's the associate director for the development of medications. He's a lead of personalized medicine at the Research Institute in Nashville, Tennessee, in the United States. Obviously, Dr. Bauer will give his talk in English. Therefore, everyone, you have the option of hearing this in Portuguese or English if you want to practice it. So at the top of your screen, which is a different screen from Zoom, there is the option to select to hear all the audio in Portuguese or English, and we're going to have the simultaneous translation. Thereafter, after Todd Bauer's presentation, we're going to have the Q&A time. Should you have any questions, please submit them over the web chat, and we will give them to Dr. Bauer, and then we can discuss. Now I'm going to change very quickly to the English channel just to welcome Dr. Bauer, and then I'm going to do the Q&A directly in English to him.
Bauer, welcome. Thank you
there.
for joining us tonight. It's a pleasure to have you here. The stage is yours. You can start as soon as you're ready. Okay, thank you.
Great, thank you much. It's a pleasure to be here, and I greatly appreciate the opportunity and appreciate everyone's time this evening. I know you've probably all had a long day, and so I appreciate your time. We're going to talk today about the evolving treatment landscape in ALK-positive non-small cell lung cancer. We are going to talk about lorlatinib a lot, but a lot of other options, because this is a good problem to have in where we are in treating ALK-positive lung cancer. We have a lot of options. It's almost an embarrassment of riches where, 10 years ago we had nothing, and now we don't know what to use first because we have so many. I do want to run through a case with you and look at lorlatinib in the first line, because this is the most recent approval for lorlatinib. And then one interesting thing about lorlatinib is that it is a newer generation of ALK inhibitor. It's a third generation, and it does carry with it some different side effects. So I want to share with you about those side effects and talk with you about how we can maybe manage those in a way that's good for patients and allows us to continue them on this therapy. So when I talk about embarrassment of riches, what do I mean? Well, if you look back to 2011, that's when we first approved crizotinib. And for those of you who might remember, the first publication on EML4 ALK as an oncogenic driver was published August 7th of 2007. So roughly 4 weeks or 4 years and 2 weeks after that, we had an accelerated approval of crizotinib, almost an unheard of speed for approval of a drug. And then since that time, in the last decade, we've had the approval of ceritinib, alectinib, brigatinib, most recently lorlatinib, and likely soon to be ensartinib, based on their first line data against crizotinib as a comparator arm. Now, when we try and think about what is the right way to pick these drugs, I think there are really two ways we can look at that. We can look at the basic science of how the drugs work and how they're different, and we can look at the clinical applications of those drugs and how they're different when we give them to patients. Now, one thing that has become an evolving question is, are all of the EML4 ALK translocations the same? And they're not. You guys are starting to hear this, I assume, and this is really just in the past year or two. We know that the different fusion points where EML4 and ALK can refuse happen in different places. We actually have them all the way out to variant 8, A and B. Now, how does that matter and what do those numbers look like? Well, predominantly EML4 ALK variant 3 and EML4 ALK variant 1 are the two most common, accounting for roughly 60 to 70% of all of those variants. So they're the predominant ones. So if we want to treat those, the majority of ALK patients the most effectively, we would then want to find the ALK inhibitor that is the most sensitive for those or attacks those the greatest. How can we do this? Well, this is what's called a heat map or a stoplight map. For those of us who are colorblind, it feels like a little bit of cruel and unusual joke at our expense. But the way that you read this is if you look at the top line on both sides, to the left of your screen, ALK variant 1, and to the right, ALK variant 3, this describes the IC50 for each of these approved drugs against that wild type fusion. So without any resistance mutations that can develop. Left to right, crizotinib, ceritinib, ensartinib, alectinib, brigatinib, and lorlatinib. The numbers in those show the IC50. Remember, with IC50, the smaller the number, the better. So you see that crizotinib does work against ALK variant 1, but its IC50 is 23. If you go down to lorlatinib, that's 2 log folds smaller, or that much more potent, and IC50 is 0.26. If you look at variant 3, we see a similar trend from 205 at crizotinib down to 4.46 with lorlatinib. So with each of those drugs, that smaller number suggests it is more potent against that particular variant. We can also use this if we go down the left column and look for that G1202R resistance mutation, where that's the one that evolves in a lot of cases to the application of the second generation ALK inhibitors, alectinib and brigatinib, and renders them ineffective. And we see that as that IC50 goes up to even greater than 1,000 with alectinib, whereas with lorlatinib, we still have a very good IC50 of 35.7 in the variant 3, and then 38 in the variant 1. So whether it be up front in the wild type EML4 ALK fusion, or in an EML4 ALK fusion that has developed a resistance mutation such as G1202R, we can see that the basic science points us to lorlatinib as being the most effective. Now, this is a slightly different way to look at it, and I will give Dr. Ignatius Wu much appreciation for letting me borrow this slide and a couple others through here. We see on a bar graph, here the comparison of IC50s. The ALK variant 1 at 23.3 down to 0.267. So for me, this is a better representation because I don't do the gradations of color that we see on that stoplight diagram, but I can certainly see this dramatic difference between 205.3 down to 4.5. So there is a difference in how potent these drugs are as we treat patients. Now, let's look at the data from the first line studies. So for alectinib, we had the ALEX study, which is the most mature data. It's been out the longest. We have ALTA-1L for brigatinib. We have the EXALT study for ensartinib and the CROWN study for lorlatinib. These studies were shockingly similar in their, I guess not shockingly, they were all looking for the same data. So they ended up being very similar in their numbers, about 300 patients. And they looked at first line investigative agent versus first line crizotinib, which at the start of all these studies was the standard comparator. Of course, the ALEX study came out first and very rapidly displaced crizotinib as a first line based on their objective response rate of 83% versus 75%. The median progression-free survival in these two arms was 26 months versus 10.4 months, with a hazard ratio of 0.5. Really impressive intracranial response rate at 81% versus 50, and a complete response rate of almost 40%. Now, one thing I do think is worthwhile noting is the ALEX study, these response rates were investigator assessed, not blinded independent central review. The other 3 first-line studies did have that. So let's walk through those and see how they differ. Because we look at brigatinib and you have a 74 versus 62% response rate, a little bit lower on both ends, 74 versus 67 for ensartinib, and lorlatinib right there with those at 76% versus 58. So all of these drugs are effective in achieving an objective response the second and third generation drugs, those being tested against crizotinib, certainly better. Here's where we see the true efficacy roll out differently. The median progression-free survival as assessed by a blinded independent review committee. We mentioned 26 versus 10 months for alectinib. Brigatinib, very similar, a similar hazard ratio, 0.49, showing 24 versus 11 months. Ensartinib, exactly the same, 26 versus 13, and a hazard ratio of 0.51. And here's where we see a first break in that trend. The crizotinib median PFS was 9.3, and the lorlatinib PFS was not yet reached with a hazard ratio of 0.28. And that's the blinded independent review. And we again look at the intracranial response rates. All of these second and third generation drugs do work well in the brain. The question is, how well do they work? So 81%, 78%, 64% response rates, and 82% response rate for lorlatinib. But when you look at those complete responses, 38%, 11% for brigatinib, 27% for ensartinib, but a 71% complete response rate in the brain for lorlatinib. So we've seen some of the preclinical data that says that lorlatinib seems to be the most potent ALK inhibitor out there. And here we see the clinical data. And this is where I need to stop and say that line that is the most common line ever uttered at every single international meeting that we all go to. We should not be doing cross-trial comparison, but, right? So we shouldn't be doing cross-trial comparison. But in this world of very focused medicines with very few patients out there, we're forced to the best of our ability, to compare them and interpret them in the best that we're able. So this would suggest that lorlatinib seems to be the most potent preclinically and also the most potent as far as intracranial complete responses go in patients. Now, this is a great slide that Christine Lovely allowed me to borrow from her. She presented ESMO 2020, and this is a progression of that data. So what we looked at in the last slide was the initial data cut, what they presented at baseline. What I think is cool to look at about this slide is at 38 months, what we see is the data for alectinib isn't getting worse. It's not like we lose that effect. It actually gets better. We see that PFS has gone out to 35 months, which is increased from 26 months, and the hazard ratios dropped to 0.43. Similarly, we see in the brigatinib, the ALTA-1L, maintenance of those good numbers from the first data cut, and we just don't have that yet for EXALT and for CROWN. So again, what we have to do in this cross-trial comparison world is do the best we can to not try and, or to understand what we're looking at. The data is different groups of patients, but knowing that they're all about the same, can we interpret that and understand? I think this may be one of the most important slides I share with you tonight. And it has to do with how well these drugs are managed and how toxic they may be. Lorlatinib got approved based on some phase 1-2 data in which it was used in heavily pretreated patients, both with radiation, patients who had CNS disease, and patients who received multiple prior tyrosine kinase inhibitors. And so there became this discussion about the CNS side effects. And let me be clear, there are very real CNS side effects associated with lorlatinib. I actually was able to review a paper recently that said that the other ALK inhibitors may have similar rates also, or maybe not the same, but also do cause some CNS toxicity. But that's been a knock on lorlatinib to date, is that it causes these horrible CNS side effects and patients can't stand on it or can't stay on it. So I think what we have to do in that case is look at the data, cross-trial or not, and try and do the best that we can for the data. So what we see is the serious treatment-related adverse events. Lorlatinib and crizotinib both are at 34 and 27%. We see alectinib a bit less at 28, similar for crizotinib though. Brigatinib 28 and 29%, and ensartinib and criz in the ensartinib study, 24 and 20%. So the crizotinib arm looks about the same. 20% of patients will have serious treatment-related adverse events. But what about those adverse events that lead to dose reduction? And this is where flags may start to go up in your mind. Look at that. Half of patients had to be reduced. But also on this study, half of the crizotinib patients were reduced as well. That's significantly different than we look at alectinib, brigatinib, and ensartinib comparator arms, where it's closer to 20 to 30%. So again, cross-trial, it's tough to know what that means, but Yes, more patients on lorlatinib had to be reduced than any other arm. Let's look at how many patients had to stop, though. When we did reduce lorlatinib, only 7% of patients had to discontinue based upon those treatment-related adverse events, suggestive that if you do aggressively discontinue, or not even aggressively, if you do when called to, patients can tolerate the drug and stay on it. No way to compare this statistically. However, you would have to say that comparing lorlatinib's discontinuation rate at 7% is certainly not worse than that of alectinib at 11%, regatinib at 12%, and ensartinib at 9%. So I think where we have to think about this a little bit is if we're looking at the data that says we got to follow the data, right? That's our mantra. Yes, we had to reduce more patients. So maybe it's a little bit more of an onus on us to pay attention to these newer side effects that we aren't maybe so comfortable with. Think about managing the autoimmune toxicities when we first started using the checkpoint inhibitors. It got a little angst inducing for us who are really good at managing cytotoxic side effects. But what about these things that are a little bit different? But if we do learn how to manage them, which is dose reduction, patients can stay on this drug and in some cases get incredible benefit from it. So when we think about how do we approach it, going back to that basic science, going back to what we see in CNS response rate, and going back to what we see in ability to stay on the drug with appropriate medical management, I really think I break this down into two primary areas. And you guys all know that ALK-positive lung cancer tends to go to the brain. 30 to 40% of patients will present at diagnosis with CNS metastases. And that 60 to 70% who don't, I believe it's about 40% of them will have developed a metastasis within a year in their brain. So that's the primary thing for me. If I have a patient who has ALK-positive lung cancer, they have a CNS metastasis, and I'm not knocking alectinib and regatinib's ability to get across the blood-brain barrier and help control that disease, but it's tough to argue with a 71% complete response rate in the brain. Then when I look at those patients who are absent in the baseline, I have a very frank discussion. Look, this is the fun part of our jobs, is there's no algorithm that says you have to do this and everything. This is the art of medicine, right? I'm going to sit down with every patient, have a discussion about what's their life look like? What do they do for a living? What is their tolerance for the potential development of a brain metastasis? Because if they're like, that terrifies me, I don't want to do it, we have to base their treatment on what's the most effective in the brain. So let's look into that a little bit. So these are a comparison of the different TKIs, their hazard ratio for progression-free survival. When we look at the overall intention to treat population, here's the 0.28 number for lorlatinib and everything else hanging out at about 0.5. When we look at patients who do not have brain mets, what I want you to see is you have a little bit of coming to the median. So lorlatinib's goes up just a touch at 0.32. Everything else, with the exception of suritinib and maybe crizotinib, come down a little bit. And I can't explain the regatinib, to be honest with you. But what that suggests to me is that outside the brain, they're a little bit closer. So what's the biggest difference? Well, the biggest difference is when you do look at patients who have brain metastases. That's the lowest progression, or the greatest hazard, the lowest hazard ratio, suggesting the greatest benefit for patients with lorlatinib is those patients who do have CNS metastases. So that suggests that the benefit is in the brain. This is the 12-month cumulative incidence of CNS progression. For patients on crizotinib, the standard of care up to just a few years ago, the cumulative incidence was 33%. When we look at lorlatinib, the cumulative incidence is 1 log fold lower at 2.8%. So very few patients will have CNS progression of their disease on lorlatinib. I do think that that's something that has to be taken into consideration. Now, again, Dr. Wu likes to play with numbers, and he's done a great job with this one. He took what was the progression-free survival and looked at it and tried to project it out for lorlatinib based on the hazard ratio. And he said, I think the projected progression-free survival is likely going to be about 33 months, which is different than this first-line data that we saw with Alta, Alex, and Exalt. Now, if you look at that investigator arm PFS, and I think he's cheating a little bit here, but it's how we treat patients is investigator interpretation. Remember that hazard ratio was down to 0.21 versus the 9.1 of crizotinib, the PFS. And he translates that out to a 43.3 month PFS. So this is a little bit very clear. This is post hoc analysis, and this is not cold hard data that I just preached we need to pay attention to, but it does suggest that we're likely to see a bit of difference in these drugs as we get some more mature data from the CROWN study. Now, I hope that that's been a good review of the data for these drugs. I'd like to walk you through a case now, if that's okay. I'm going to check the time to make sure I'm not talking too long. You give me an open mic and free reign, and I can go on for days. Just ask my kids. So what I want to present to you now is a healthy 58-year-old who presented with a cough just over a year ago and was found to have a 3-centimeter right lower lobe lesion. He went for curative intent resection, but unfortunately level 7 and 8 nodes were positive at the time of resection. So the resection was aborted, and he was diagnosed with the stage 3 non-small cell lung cancer. He was ALK positive on both blood-based and solid tissue profiling. Now, there was a decision made to treat for cure with concurrent carbotaxol and radiation, and this was administered September through November of 2020. Unfortunately, his first set of restaging scans did demonstrate 2 primary CNS lesions that were not there prior to initiating that, which again speaks to the way that lorlatinib, or the way that ALK positive disease progresses in patients. This patient was started on lorlatinib December 8th of 2020, and he did have good tolerance with no CNS side effects. But what you do see are one of the other more unique side effects of lorlatinib, actually the most common side effects we see, elevations of cholesterol and triglycerides. This is a relatively healthy patient whose baseline cholesterol was about just under 300 and rapidly rose up to almost 400. Triglycerides also just under 150 and rapidly rose up to 300. So these are real side effects, and shortly we're going to talk about how to manage those and how to think about them. The patient had restaging scan 2 months later, and what you see is this CNS lesion has completely resolved. The other CNS lesion resolved as well. So this patient too had a complete response after 2 months on lorlatinib to primary progressive disease in the brain. So that right there is a perfect case for demonstrating why I think it's important that we consider these different drugs and how they work, especially with respect to the phenotype of ALK positive lung cancer, which loves to go to the brain. Now, it's a 3rd generation ALK inhibitor. It has a macrocyclic molecule. It's not a linear molecule as the other ALK inhibitors are, and it does get into the brain better. It carries with it some unique side effects I'd like to focus on. So hypercholesterolemia and hypertriglyceridemia are the most common side effects we see. In fact, you'll see 82% and 60% respectively all grade toxicities. We do see some edema, one of the more common reasons to have to hold lorlatinib. So we saw some peripheral neuropathy. And then we get down into some of these CNS side effects, cognitive effects, mood effects. There's also a weight increase that I can share a great story with you if we have time at the end. In general, for grade 1 or mild side effects, you may continue dosing lorlatinib or withhold and wait till that side effect resolves. And then you can either re-challenge at the same dose, or if a discussion with the patient suggests they aren't comfortable with that, you can lower it by 1 dose level. Now, remember the recommended starting dose of lorlatinib is 100 milligrams once a day. The first reduction is 75 milligrams. The second and final reduction is 50 milligrams. If they can't tolerate that dose, it should be discontinued. If patients have moderate or severe grade 2 or 3 toxicities, lorlatinib should be withheld, dose reduced after they've reinstituted once they have dropped to grade 1 or better side effect. And if a patient has grade 4 side effects, there needs to be very serious consideration of permanently discontinuing lorlatinib, which is the recommendation. Now, what do we do about dose interruptions, reductions, and permanent discontinuations? So what we've talked about so far has been phase 1 data and the phase 2-3 data. The dose reductions that we're going to talk about were that phase 2-3 registrational data, okay, not the phase 1. So the temporary dose interruptions and reductions were reported in 22 and 19.7% of patients. So less so than we saw in that frontline data, which I think probably actually speaks to the experience of patients on a first-line therapy versus on a third or fourth-line therapy, where they may be a little bit more tolerant of those side effects and more open to accepting them going forward. The most common cause for dose interruption modifications was edema at 5.8 and 6.1% of patients. Incidence of permanent discontinuations due to adverse reactions was even lower in this group at 2%. And those that led to them were cognitive and mood disorder with 2 patients each, and edema and fatigue in 1 patient each. Now, when do we see these side effects emerge? Ignatius kind of charted some of this out for himself and said, look, if we're going to have any of these feared acute psychotic issues with hallucinations or sleep terrors, we tend to see those very quickly in the first month. We start to see any kind of cognitive changes or personality changes over the first couple months. And then starting later on, typically, and slowly evolving, are the appetite increase, slow speech, and the lipids. Now, I would actually move the lipids up a little bit earlier. In fact, with the lipids, I check it before they start. I check lipids at 2 weeks, at 4 weeks, and monthly thereafter, and just tell the patients to expect that they're going to have to start some treatment for that. We'll go into that here shortly. Now, this is a very busy slide, and please don't try and read every word on it. I have this slide here because I think it's important that we all remember the cognitive mood effects of this drug. We only see our patients, best case, for 15 to 20 minutes, once or twice a month, maybe. And after that, we don't see them. And so it's easy for us as physicians, I think, to miss subtle changes in mood or cognition. And it's really important with orlatinib to empower the caregivers, the loved ones, family, and friends of the patients who come to see us to be aware of these and to make us aware if they're seeing them at home. Because I may not notice that Miss Smith's speech has slowed down a little bit. I live in the South in the United States, where we are notorious for a very slow Southern drawl, where people talk slow a lot. So it's sometimes tough for me to pick up on that. But loved ones are usually acutely aware of, dad's sleeping more than he normally does. He's not wanting to eat. His buddy called him and asked him to go play golf, and he said just didn't have any interest. So kind of those depressive symptoms. That's where empowering your caregivers is really important and really helpful. Now, what do those CNS side effects look like? We lump these together because there are subtle differences between them. We saw cognition, mood, and speech as being the most common. They were generally, however, mild, intermittent, and they did improve with dose modifications. These adverse drug reactions were reported a frequency of 39.7%, with 12% of patients experiencing more than one of them. Of note, there were 72% of patients that had baseline CNS metastases. And remembering in this phase 2-3 data, the phase 1-2 data, a lot of these patients were heavily pretreated. A total of 24 patients required at least one dose modification as a result of these CNS effects. And 15 of those patients experienced resolution of that, with a median time to resolution of 12.5 days. Recurrence of CNS side effects at the same and reduced dose did occur, however, in 6 and 7 patients respectively. So my thoughts on that, of course, would be to hold it again and reduce the drug the first time or the second time if necessary. Again, only 12% of patients ended up with multiple of these. You see the most common were cognition and mood, and that was also the most common joint effect. Only 6% or 6 patients or 5% experienced the triumvirate of mood, speech, and cognition. How do we manage this? Again, for grade 1, we typically continue them at the same dose, potentially reducing it if the patient is upset by this or distraught. Now, this is more for the cognition stuff. And I fortunately have not had any of the psychotic issues that have been reported in a very few patients. Obviously, that would result in a drug hold, resolution, and reducing the dose. If it's a little bit of slowed speech or a little bit of cognition issue, that's a very good discussion to have with the patient about how is it affecting their daily life, and do we need to reduce it or can we continue it? If those are moderate or severe, we hold and reduce the dose and rechallenge. If it's grade 4, then that's when we would talk about permanently discontinuing orlatinib. Now, this was some of Ben Solomon's data from our study that was presented at ESMO just this fall. And it looks at what happens for these CNS adverse events if we manage them appropriately. So it's a lot of numbers on here. Let me walk you through it. The total number of events was 86. 53 of those patients, there were no intervention taken on. 28 of them had resolution without doing a thing. One of them had resolved, 24 had not resolved. Now, on the 31 patients who we did intervene upon, 20 of them, or over half of them, had resolution of those side effects. What were those interventions? Well, CM is ConMed. For depression, we added Alexapro or something along those lines. Dose modification plus a ConMed, and then you get into dose reduction, dose interruption, reduction, plus all the different variant ways that we go through and manage these. The important thing to notice is that with management of these, very few patients did not have resolution of their CNS side effects. So though they may develop them, typical management with just simple reduction is an effective strategy for managing these side effects. I want to go back and share with you, I think we have a few extra minutes tonight. So I want to share a case with you of mine and a gentleman. He's actually was not the second patient, but maybe the third or fourth patient ever dosed with lorlatinib. He was on the phase 1 study with me. He's been on this drug for over 7.5 years at this point. He was on the recommended dose at 100. And at one point we had to reduce him to 75. And about 3.5 years ago, we reduced his dosing to 50 milligrams. And we did that because he presented with new onset seizures. He'd had a history of CNS metastases. He had a history of whole brain radiotherapy in 2014 before he was my patient. And I was terrified, of course, that he had progression of disease in the brain. We withheld the lorlatinib, again, dosing at 75 milligrams a day. And about 7 or 8 days after we held it, all of his symptoms went away. He had no further confusion, no further seizure effect. And we had a very long, in-depth discussion about, do you feel safe resuming this at dose reduction? He's like, yeah, this drug has saved my life for 4 years. I want to try more. So we put him on the 50 milligram dose, and he has continued on that for 3.5 years with no recurrence of those symptoms. Now, this story in my mind is important for 2 reasons. One, it shows even profound CNS toxicity, because I didn't find a better reason for those seizures than this drug. Even profound CNS toxicity can be managed and overcome by dose reduction. And 2, even at a 50% dose reduction from starting dose, patients can maintain good, durable response. And he has a very near CR. The only reason he's not is because a radiologist who I fight with every 3 months when he gets scans now says he still has like a 4 millimeter residual something in his brain that has been 4 millimeters for like 6 years. So I'm pretty sure it's just scar tissue, but he won't give me that CR. So well tolerated when we manage it, and still good benefit at the 50 milligram or even lower doses. So the hyperlipidemia, I mentioned that's the most common thing we see. Again, I share with my patient, I just fully expect that their cholesterol is going to go up, and we're going to have to manage that with statins. They were seen in 82 and 61% of patients, as I mentioned, and most of these are grade 1 or 2. Those that were grade 3 or 4 were patients who thought they could exercise their way out of it or didn't want to start a statin for one reason or another. These were not common reasons for dose delay or dose reduction. There were no permanent treatment discontinuations for hyperlipidemia. I typically think about the lipids just like I think about hypothyroidism in a patient who I'm treating with an immune checkpoint inhibitor, right? You see their TSH go down, you see their TSH rocket up, you start them on Synthroid and you don't bat an eye. You don't delay the treatment, you don't take them off, you just manage it and it goes fine. That's how the cholesterol management is with lorlatinib. Now, again, until you get to life-threatening cholesterol over greater than 500 and triglycerides greater than 1,000, even at that, I still probably tend to treat through it as long as the patient will start a statin. If they won't start a statin at that point, I will withhold the drug to make sure it comes down. Now, one of the really important points of this is one of those fine details. Due to CYP450 enzyme interaction, pitavastatin, pravastatin, or rosuvastatin should be the first-line therapies. Using the older statins, they do interact more with CYP450, and that can interact with lorlatinib. It can increase actually pretty significant side effect profiles in these patients. So we tell the patients how to monitor it. I've shared with you before, it's at prior to starting at 2 weeks, 4 weeks, and monthly thereafter. Now, there are some more recently described events as we've dosed more patients with it, and we're seeing numbers that were too small to kind of raise our attention in the earlier studies. But hypertension and hyperglycemia, we're seeing in 13% and 9.2% of all patients. The management for these is just along that same kind of pathway we've talked about 3 or 4 times now. Grade 1 or 2, it's medical management of those side effects that emerge. If we get to grade 3, you hold the drug and resume when you've managed them down to grade 1. If we get to grade 4, hold it, reduce the dose, continue the management. If you can't get them under a grade 4 with maximal medical management, then it may be that we have to discontinue the lorlatinib. So guys, those are all the slides that I have. I hope that you found this helpful so far, and I look forward to a great discussion for the next 25, 30 minutes.
Yes, thank you, Dr. Bauer, for this brilliant presentation. Just to remind our audience, if you have questions, please send it via chat, and we can ask for Dr. Bauer, okay? Dr. Bauer, I have a few questions for you.
Sure.
To start, okay? So the first one, in Brazil, we have 2 options of next generation anti-ALK in first line, right? Lorlatinib and alectinib. And of course, most of us, we use alectinib because it's been the longest approved drug. So my question is how to select in first line between alectinib and lorlatinib. Lorlatinib for CNS metastasis, alectinib for patients without, lorlatinib for everyone. You know, I know that is a trick question, but it's our day, right? And we will ask a question.
Yeah, and I think that so the generosity of Pfizer is sponsoring this talk. So I think the company line would be put it in the water and give everybody lorlatinib. I don't think that's necessarily the right answer. And I've had a lot of discussions with a lot of other investigators. You know, you talk to Ignatius Wu, and he's probably a bigger fan of this drug than I am. And it's hard to find somebody a bigger fan than this. Like, so remember, this was the first drug in my career in phase 1 drug development that I saw from first in human dosing to FDA approval. This is like, I've seen my child grow up and graduate college and they're off doing great, right? Like, I'm proud of them. They deserved attention every once in a while though, right? So nothing is perfect. I think about it this way. Well, there are 2 ways. I'm going to talk out of both sides of my mouth for a minute, if you'll forgive me. One is the more practical way. If a patient has brain metastasis, lorlatinib is clearly, in my mind, a better drug than the other drugs out there. The others aren't bad. I'm not saying that, but I think lorlatinib is a step function better.
Right.
It gets a little bit more into some gray areas if you look at no brain mets present. When we started developing lorlatinib, the most important thing to me was that it represented a rescue drug to patients who had been on other second generation ALK inhibitors, because it could target that G1202R resistance mutation so effectively. So I don't know if you guys will know who Mariano Rivera was. He was a relief pitcher for the New York Yankees, best guy in the world. And in my mind, that was what lorlatinib's role was when we started. Lorlatinib could come in and save the game when it was about to get out of hand. That's not a bad way to be. The alternative would be to say, well, based on the preclinical data, based on the CNS efficacy, lorlatinib is the best drug in the world for this. Lionel Messi doesn't come in off the bench, right? He starts the game. You don't want to save him to try and save you when you get down 3 games. You should just go ahead and win the game, right? So it really depends on how you think about that. I told you I was going to talk out of both sides of my mouth. I'm not trying to not answer the question. It's just, it's very nuanced. If there are brain mets present, lorlatinib is my go-to drug.
Good.
If there are not brain mets present, it's a very in-depth discussion with the patient about, do we go with the most potent thing up front, or do we try and save something for a rainy day?
Yes, perfect. I completely agree. But I believe that the point of concern of medical oncologists of starting with lorlatinib is that what to do after failing lorlatinib. So what's your option? Do you consider rebiopsy? Is it important to do? Or chemo plus IO, chemotherapy alone? What's the best option after lorlatinib? How do you deal with this situation?
Sure, and that's a great question, and one I'm going to get to take in a couple different directions. So I've got 3 points. If I forget them, you're going to have to remind me, all right? Number one is, ideally, once someone has progressed on a second or third generation ALK inhibitor, we could resequence just the ALK gene. You can do that through a liquid biopsy and find what the resistance mutation was. It's interesting, if you look at the phase 2-3 data for lorlatinib, those patients who had prior ALK inhibitors, when we sequenced them, if we could identify the resistance mutation versus not being able to show a resistance mutation, the response rate was dramatically different, suggesting that if we didn't find a resistance mutation within the ALK fusion, they had developed a bypass tract, and it didn't really matter what ALK inhibitor you put them on, it wasn't going to work. So that would be helpful there. You could also look at the resistance mutation and see if you do lorlatinib first, which of the other two might be more sensitive or more potent against that particular resistance mutation. If someone has been on alectinib or brigatinib first line, the scientific pure answer is to do the testing, but I think the clinically expedient is just to start them on lorlatinib because likely they're going to respond to that.
Yep.
So that's the sequencing question. Then you ask, well, let's say they've been on alectinib and they've been on lorlatinib and now they progress. Do I put them on chemo? Do I put them on chemo IO? What do I do? Well, how do they progress is an important question. Yep. If they progress with an oligoprogressive lesion in the lung or the liver and disease is stable elsewhere, I actually strongly consider the use of palliative radiotherapy, use stereotactic radiosurgery, because we know these tumors are so heterogeneous that if I can control 95% of the disease with the drug, and I've done so for a long time, if I can then treat them locally with radiation, maybe they don't have progression for another 6 or 8 months still on lorlatinib. So that's 2. 3 is the chemo or chemo IO question.
Yep.
We have not seen so far that immunotherapy works well in these molecularly driven tumors, most specifically in ALK positive disease. So I do not use checkpoint inhibitors in ALK positive patients. Not to say I wouldn't consider adding a little bit of chemo to an ongoing ALK inhibitor. Again, sort of think about continuing androgen deprivation therapy for a prostate cancer patient, because we do sometimes see tumor flare when we hold these ALK inhibitors in patients whose diseases are so ALK dependent.
Right.
So I hope that covers all of those.
Yes. Thank you. And another point of discussion is, especially in ALK disease, is how to deal with CNS metastases, right?
Yeah.
And normally when a patient has CNS metastases and is ALK positive, we normally consider SBRT, stereotactic radiotherapy. In parallel, we will start with ALK inhibitors, mainly if the patient is symptomatic, right? If the patient is symptomatic. In patients that are asymptomatic, we mainly start only the systemic therapy. But with lorlatinib, we have very high activity in CNS metastases. And my question is, could you consider omitting radiotherapy in a patient with symptomatic brain metastases if we will start lorlatinib? Of course, if the symptoms are controlled with steroids or anticonvulsivants, for example, is this possible to omitting radiotherapy?
Yeah, I think that, again, this is a judgment call that's individual with each patient. I've had the chance to use lorlatinib enough and have seen how well and how quickly, and that's important, it can work in the brain. It's one of those drugs like we have with a lot of the TKIs. When a patient walks in 3 weeks later and is like, it's working because I can breathe better, like that's real. They're not making that up in wishful thinking there. No. It probably depends on the degree of symptoms. If a patient presents with seizures and they've got midline shift, I don't know. That's tough to hold off on radiation in that case. Yep. But if they come in, we find it and they've got some mild headaches, maybe some balance stuff, and I put them on steroids and they feel better. Yeah, I think it's okay. Now I'll get a scan again at 1 month after being on treatment and expect to see that the disease is smaller. I won't wait 2 months for an MRI. But if I can control those symptoms with steroids and spare that patient of stereotactic radiosurgery and the side effects, I'll do it. And I think this is, I refer back to my patient who's been on for 7.5 years. He, I think, had 3 or 4 brain mets when he progressed on crizotinib in the brain. And at that point, 2013, 2014, he just went for whole brain radiotherapy. Now we're doing SRS on 5, 10 lesions. But what we're now seeing in this particular patient is what do the effects of whole brain radiotherapy look 7 years later? We never have to used to worry about that problem. Yeah. And I think even as we do more SRS is much better of a technique as I think that is, I think it's still going to have some long-term side effects. So the more we can spare patients that, the better we do for them.
Yes, perfect. And the second question is in this regard, because is it possible that the radiotherapy increase the chance of neurological symptoms with lorlatinib? Is it possible?
I don't know the answer to that is my first line.
Right, perfect.
I think that probably where a lot of the neuro side effects or the worry about those may have come from is, again, seeing these patients who'd had whole brain radiotherapy or rounds of stereotactic radiotherapy, maybe even had active CNS metastases, and had been on crizotinib and alectinib and brigatinib and chemo and then ceritinib. So super heavily pretreated, like that's got to have an effect on the brain. The first line data didn't show quite the degree of CNS side effects in patients who'd not been so heavily pretreated and hadn't had the radiation. So could the radiation predispose them to that? I don't think in a mechanistic way it makes them more susceptible to those CNS side effects from lorlatinib. I just think that radiation to the brain has bad long-term consequences.
Okay, right. And the last question about CNS metastasis. For example, if we have a patient with oligometastatic disease, we start with lorlatinib and we have a partial response in CNS, right? Mm-hmm. We have now only 1 lesion after 3-4 months of lorlatinib. Would you consider consolidation radiotherapy for these residual lesions, or, just observation and
I probably, and this is a thoracic residual disease or CNS residual?
No, CNS residual disease. CNS.
As long as it's not growing, I probably wouldn't put radiation to that. As someone said on a meeting a couple of weeks ago, and I've not had the courage yet to say this to a patient, but I get the statement: stable disease never killed anybody. Like that's kind of a in-your-face, rugged description, right? But that's true. If we're keeping disease stable, and they're not having symptoms, maybe we don't need to radiate that.
Okay, and we have a few minutes. Let me discuss a few questions about side effects, right?
Sure.
You showed that the most common cause of those interruptions and those modifications was edema, right? Mm-hmm. 5 to 6% of patients. Do you have any tips on how to deal with these adverse events? Because sometimes it's hard to deal with that, right?
Yeah, absolutely. So I will typically try first before I reduce. If they come in and say, "Hey, I've gained some swelling in my legs," I will try to use Lasix to try and just draw some fluid off. Failing that, I will reduce the drug, and most patients are able to tolerate it at a reduced level. I've not held anybody for the edema yet because edema to me is for the most part can be very uncomfortable. It isn't dangerous for a patient. And
Yeah.
so I will try and treat through it. If I can't, then I'll reduce it. And I've been able to manage it that way pretty well.
Right. And diuretic, do you think, is it important? And do you consider use diuretics?
Yeah, I will try a loop diuretic like Lasix to try and get that fluid off. I can't say it's super effective, but I'd rather try that, a pretty benign medicine, than reducing the dose of this.
Nice. And another question about adverse events is about let me see. It's clear that neurological and cognitive events are the ones that cause the most concerns for oncologists,
Sure.
right? On the other hand, the drug activity in the CNS is high. And the question is, the frequency of cognitive and neurological side effects are more frequently between patients with CNS metastasis. Do you have information about that?
I don't know that I have the breakdown on that off the top of my head. It's probably buried somewhere in some of the post hoc analysis. But, looking at the phase 2-3 data where, was it 70 to 80% of patients had CNS metastases present on enrollment, whether treated or not. I got to believe that that's playing some role in it. But again, I don't want to discount these CNS side effects. I've seen them, mostly the cognition and speech and mood. I fortunately have not seen any of the psychotic issues that we've seen, and those have been fairly dramatic when described.
Okay.
But it's not clear to me for sure that there's a correlation between presence of brain mets and those side effects.
Okay, and for about these CNS side effects, is there a patient profile for which lorlatinib is you consider contraindicated because of the risk of the side effects?
I don't think so. We looked at a couple different cognition evaluations and suicide. I'm trying to think, what was the Columbia Suicide Severity Index, and looking for trends toward worsening of suicidal ideation or depression. And we didn't see any clear trend across that in any of the studies, whether it be the phase 1, the phase 2-3, or the Crown study. So I've never, now, if I have a patient who comes in and they have a history of schizophrenia and they're on antipsychotics, that might push me to look at alectinib as a first line agent, for sure.
Okay.
Like I'm
right.
I'm bold. I'm not stupid. So I would try other things.
Of course.
But I'm not sure it's an absolute contraindication.
Okay. I believe we have a question from the audience.
Okay.
Dr. Berta Mendes. Let me read it. After treating with Lola and having complete response in CNS, is it necessary to treat the CNS or wait to treat after new progression? I believe you covered, right?
I think so. Yeah. If we've got a complete response in the brain, there's no benefit to adding radiation at that point.
Yes. Just observation, right?
Yeah.
Yes. Perfect. So I believe we are at the top of time. I believe we covered the most important points. So, I think we can finish here. So thank you, Dr. Todd. It was a great pleasure for me to have this discussion with you. Okay.
Great. Thank you very much. Appreciate everybody's time. Pfizer for hosting this and for the team putting it together, making it so easy for me. And thanks, guys. I wish it weren't COVID and I could have made a trip to Brazil. I've never been, would love to. Maybe next year. Yes,
for sure. Thank you. Okay. For the audience, before we finish, we have a QR code that is shared on the screen. If you, we would appreciate if you can answer this satisfaction questionnaire. Okay. Thank you, everyone. Thank you again, Dr. Bauer. Bye-bye.
Thanks, guys. Bye-bye.